This is the constituents of the plasma components. As we all know that the transport mechanism in blood is the plasma, which is composed mostly 90 or 92% of it is composed of water, and almost 7% is protein, and around 3% fats, carbohydrates, electrolytes, gases, chemical messengers, etc. So this is the plasma component, and we'll see now how this will affect the procedure of apheresis. It's very important to know the distribution volume of immunoglobulins and the molecular weights, which I will come to it later, of the different substances, because that's the whole philosophy of plasmapheresis, but whether by centrifuge or by filtration method. Albumin, the molecular weight of albumin is 69,000 Daltons or 69 kilodalton. IgG is 180 kilodalton, IgA 150 kilodalton, IgM 900 kilodalton, and low density lipoprotein cholesterol is 1,300,000 Daltons or 1,300 kilodaltons. It's a very big molecule. So cytokine molecular weights, as we all know, these are the different cytokines. Of course, the most important now, which is the star of the COVID era, is the interleukin-6 homodimer. And as we see, its molecular weight is between 19 to 26,000 Daltons or 19 to 26 kilodaltons. Again, one of the important cytokines is the tissue necrosis factor, homotrimer. Its molecular weight is 26 kilodalton, and this is also another very important mediator in the inflammation process. So this diagram is very nice, and it shows us the spectrum of filtration of different modalities. As we can see that small molecules like BUN and creatinine are removed by hemodialysis with diffusion clearance, because the pores of the hemodialyzers are very narrow, so they can only permit these very small and tiny molecules to pass through without, and the others, the bigger ones, are not allowed to pass. So the other middle molecules, which are very important also in the inflammatory process, they can be removed by hemofiltration, by convention clearance, and these substances has bigger molecular weights than the urea and creatinine. And as we see that the middle molecules can be removed with high flux hemodialyzer with a good sieving coefficient, and but yet they have limitations regarding the molecular weights. They can permit up to 50 something kilodalton, but bigger molecules like albumin, IgG, and IgM can only be removed by therapeutic plasma exchange, where the pores of the filters are much wider. So the relationship between plasma volume removed and the concentration of substance, this is a very important thing. Again, as we said, apart from the acute liver failure, whatever you increase the plasma volume removed, you will achieve almost most of the clearance between 1 and maximum 2 plasma volumes. Of this, as far as there is no indication, as we mentioned, there will be no point of performing more plasma, filtering more plasma volume, because you will achieve almost the same clearance. So I will give you an example. At 1 plasma volume, 63% of immunoglobulins are removed. At 1.5 plasma volume, 78%, and at 2 plasma volumes, 86%. After that, the difference is, as you see, is not worth that you go with such higher plasma volumes, which will cost a lot because you will need more albumin and it might cause more harm than its benefits. Is the reaccumulation concept, which means that when you start with let's say 100% of the desired substance to be removed, after the first session, you may go down with the level of this substance to 40%. A day later, this 40% increases back to 60%. And then when you do the second, you go down to almost 20%. Again, reaccumulation occurs a day later, and the substance, due to new production of the substance increase and the redistribution from the tissues to the blood or to the plasma happens, so it increases again. After that, after performing several sessions, consecutive sessions, you see that the rate of reaccumulation becomes much lower, and the standard baseline of this substance is much reduced. And that's why in most of the cases where we perform plasma exchange, you will see that most of the protocols say that you do the first 5 sessions on consecutive days, sometimes the first 3 sessions, sometimes the first 7 sessions, according to the substance. And then you go after that every other day if you still need this technique. Because after that, the rate of reaccumulation is much lower, and you will not need a daily plasma exchange. Again, this is the same concept. This is the example of IgG removal by plasma exchange. You see pre and post, pre and post, pre and post, and then you have a new maximum point after few consecutive sessions. Replacement solution. As we all know, we have 2 replacement solutions, albumin and fresh frozen plasma. Well, the advantages of using albumin is that there is no risk of hepatitis. It is stored at room temperature. It is its allergic reactions are much less, especially with good quality human albumin. Yet it is also present, but less than fresh frozen plasma. There is no ABO matching and depletes inflammation mediators. While the advantages of fresh frozen plasma is that you introduce or infuse some coagulation factors to the patient, you give the patient also immunoglobulins and complement. The disadvantages of albumin, it is expensive. There is no coagulation factors delivered to the patient and no immunoglobulins. While the disadvantages of fresh frozen plasma is you are transfusing a plasma of a donor. So this donor might have hepatitis, have HIV, or any blood-borne disease, syphilis, etc. Allergic reactions are common. It's kind of blood transfusion. Hemolytic reactions also are common and must be warmed because it is kept into special refrigerators at a freezing point. And ABO matching should be done before infusing the fresh frozen plasma. Specific indications for fresh frozen plasma, and these are very important because, as we will see, that almost the most frequently met indication for fresh frozen plasma, in nephrology at least, is the TTP-HUS. So please bear in mind that apart from the TTP-HUS and some other very specific indications, example, the pre-existing defect in hemostasis or risk of choline esterase depletion, or when the fibrinogen level is low, below 125 milligram per deciliter, all other replacement in all indications of TPE should be by albumin. There's no role for fresh frozen plasma in other indications. And this is important because actually, let's see, يعني في أرض الواقع, what we see that some centers replace with fresh frozen plasma, claiming that the patient cannot afford, so I will give him fresh frozen plasma, it's cheaper and so forth. it's a good, I know it's very noble intentions that you are trying to reduce the cost for the patient, yet you are not benefiting this patient for other indications. You should replace by albumin. So at least in our practice, the everyday practice, the only role for fresh frozen plasma is the TTP, the complications of plasmapheresis. Some are related to vascular access. Example, hematoma, pneumothorax, in case of you applying or putting the central venous catheter, or retroperitoneal bleeding if you use it through a femoral catheter. Related to the procedure itself, hypotension from externalization of blood in the extracorporeal circuit. That's again an important thing when we choose the plasma filter size, because as we said, the small size fits the small individual. So you cannot put a large size for a tiny individual, because the blood that you will take off from the patient will be very large enough to cause hypotension for this individual. So this is an important thing. Another thing is, if there is no good sequestration, the sequential replacement of the replacement solution, if it is not matching the rate of ultrafiltration, so you might have hypotension because the patient will be ultrafiltrated and the replacement fluid is not concomitantly applied in the same rate. So sequential replacement is very important. Hypotension due to decreased intravascular oncotic pressure. This is another issue. As we mentioned, that albumin sometimes is leaked with the plasma, it's taken with the plasma, and if you are not replacing with albumin properly, the oncotic pressure will be much less, and extravasation to the third space will happen. Again, this will cause hypotension. Bleeding from reduction in plasma levels of coagulation factors. Edema formation due to decreased intravascular oncotic pressure. Loss of cellular elements, platelets, ethylene oxide associated hypersensitivity reactions. And related to anticoagulation, we have bleeding, especially with heparin, hypocalcemic symptoms with citrate, arrhythmias, hypotension, numbness and tingling of extremities, and metabolic alkalosis from citrate. Sorry. So what are the precautions we should do when we go for plasma exchange? The first thing is to avoid hypocalcemia. Hypocalcemia by prophylactic infusion of 10% calcium chloride during treatment. Hemorrhage, 2 units of fresh frozen plasma at the end of the session to replace the coagulation factors lost during the procedure. Thrombocytopenia, consider membrane plasma separation, as we mentioned, because the thrombocytes, which are also have a very minimal molecular weight, could be extracted with the plasma. And if you have the plasma separator, and then you can return back these thrombocytes to the patient. Volume-related hypotension, as we mentioned, consider continuous flow separation with matched input and output. Sequential replacement should be very sequential. The rate should be very matching, so you will not ultrafiltrate more than what you infuse, and also not vice versa. You should not introduce more than what you ultrafiltrate, because you might induce pulmonary edema to the patient. Infection post-apheresis, infusion of intravenous immunoglobulin, 100 to 400 milligram per kg, because you lose immunoglobulins, so you are more prone for infection. So it's better to infuse the immunoglobulins. Hypokalemia, so we have to ensure a potassium concentration of 4 millimole per liter in the replacement solution. Membrane biocompatibility, change membrane or consider centrifugal method of plasma separation. If you don't have a biocompatible membrane, use the centrifuge. Hypothermia. So we have to warm replacement fluids before returning them to the patient. Sensitivity to replacement fluids. We should consider diagnostic evaluation, anti-IgA antibody, anti-ethylene oxide antibody, anti-human serum albumin antibody, endotoxin assay, and the bacterial cultures of replacement fluid, etc. And consider using starch-based fluids. Pre-medication regimen for sensitized individuals, we should give prednisolone 50 milligram orally, 13 hours, and then 7 hours, and then 1 hour before treatment. So 3 doses, 13, 7, 1, and then diphenhydramine, 50 milligram orally, 1 hour before treatment, and ephedrine, 25 milligram orally, 1 hour before treatment. So some of the general orders that we should prescribe when you, in your prescription, when you prescribe a plasma exchange for a patient is calculate the plasma volume by the equation, or the most, the easiest way to do it is what we do is like you multiply 40 by the body weight, which gives you an approximate estimate of the plasma volume, or there is a formula and it can be done more accurately by the formula, and measure the pre-plasmapheresis PT, PTT, and the platelet count. And when feasible, measure the plasma level of substance targeted for removal. Example, anti-GPM antibody, TITR, acetylcholine receptor antibody, and cryoglobulin. Why? To determine the efficiency of your removal. If we started with, let's say, 100% anti-GPM, and then after the session, you measured before the redistribution and reaccumulation happened, you measured the volume of this and found that you only removed, let's say, 10%, then you are not performing an efficient session. So space treatments approximately 24 hours apart. Sometimes in some cases, the other indications you might do in every other day. Some you perform a few sessions in the first 3 or 4 or 5 sessions daily, and then you do every other day sessions. For heparin anticoagulation, low bleeding risk, low bleeding risk patients, heparin should be infused with 50 international unit per kg initially, then 1,000 unit per hour, and target ACT when baseline mean control value should be 145 seconds. During the procedure is about 180, should be 180 to 220. So if the ACT is 3 times more the average, which is 145, increase the fusion rate by 500 unit per hour. If the ACT is if the ACT was less than 3 minutes, increase the fusion rate by 500 unit per hour. If the ACT is 4 minutes or more, discontinue heparin infusion and continue to measure the ACT and resume heparin infusion at a reduced rate as appropriate. And stop heparin infusion about 30 minutes prior to the end of the procedure so you can end the procedure safely. For citrate anticoagulation, use ACDA at 1 to 15 to 1 to 25 dilution with blood. And use calcium infusion if necessary, cardiac monitoring, and administer scheduled medications only at the end of the session, because most of the medications will be removed by the plasma pheresis. So it's wise to give it post-session so as not to lose the effect of these medications. Of course, catheter care should be done as routinely and avoid any kind of infection, and make sure that you close the catheter in a proper way to avoid clotting of the catheter in the future. These are the regimens for plasma exchange in some of the important renal diseases. I will highlight a few things. As you see here, HUS, TTP, the duration for treatment is 7 to 10 days, or until platelet count is 80 to 100,000, sometimes needed twice daily in some cases. So the other indications you have also between 7 to 10, sometimes 14 days. But in HUS and TTP, you have to keep an eye on the platelet count. The limitation here is the platelet count. So if you reach this, you should stop it. Sorry, if you reach it 70 to 80 to 100,000 platelet count, then you may space the sessions, make it every other day or so. But in the beginning, with very low platelet count, you should perform it daily and sometimes twice a day. I remember a case we performed for it was a young man with severe TTP, and the guy had a platelet count of 5,000 or 10,000, not more, and he received up to 20 sessions in almost 14 days till his plasma platelet count improved. Again, in the exchange volume, the replacement fluid, the fresh frozen plasma or cryoglobulin, as we mentioned in TTP, other than this, all are replaced by human albumin, 5%, and sometimes, in some cases, 4%, as we will mention. Exchange volume generally is 50 milliliter per kg per each treatment, which is almost 1 plasma volume. In some very peculiar cases, we might increase to 1.5 or sometimes 2, but as we mentioned, you shouldn't go above this except for a very specific indication, acute liver failure. Additions to replacement fluid, it's very important to add 20 milliliter, 10% calcium gluconate occasionally. You may add more. 3 milliliter, 15% calcium chloride, if not dialysis dependent, and heparin 5,000 to 10,000 units unless citrate anticoagulation. Immunosuppression in cryoglobulinemia, prednisolone and cyclophosphamide in type 2 should be considered, but caution if hepatitis C virus positive, because this might flare up the condition or the viral load. Important variations. In anti-glomerular basement membrane disease, fresh frozen plasma, 5 to 8 milliliter per kg as part of exchange volume if hemorrhage risk. Renal biopsy in the last 48 hours, or lung hemorrhage, or platelets أقل من 40,000, or fibrinogen أقل من 1.5 gram per liter, and immune absorption may be as effective as plasma exchange. So in cases with anti-glomerular basement membrane, because the patient is a higher risk for bleeding, you may give 5 to 8 milliliter per kg fresh frozen plasma. But the replacement fluid still is the 5% albumin. This fresh frozen plasma is only to prevent the bleeding. And this is a nice